Good morning everyone. My name is Dr. Nikhil Gundeti. I am from KMC Manipal. My presentation is based on my study correlation between dyslipidemia and left ventricular diastolic dysfunction in newly detected asymptomatic type 2 diabetes mellitus population. And so coming to introduction, type 2 diabetes is a progressive or metabolic disorder that silently impacts cardiovascular structure and function even before the symptoms appear. The first detectable stage of diabetic cardiomyopathy is left ventricular diastolic dysfunction, which may remain clinically silent for years. Previous studies had shown that 40% of asymptomatic diabetes population already have this subclinical diastolic dysfunction. Dyslipidemia, a common metabolic abnormality in diabetes, is a potential contributor for myocardial stiffness, but its role in early left ventricular diastolic dysfunction is unclear. And so early detection and intervention are crucial to prevent overt heart failure in this diabetic population. So aim to study the correlation between dyslipidemia and diastolic dysfunction in newly detected type 2 diabetes mellitus population, and objectives are to study the prevalence of LVDD in asymptomatic newly diagnosed diabetes population, and to study the correlation of left ventricular diastolic dysfunction with dyslipidemia in asymptomatic newly detected type 2 diabetes mellitus, and to study the correlation with LVDD and glyco-HB levels. So this study was done at Kasturba Hospital, Manipal between February 2023 and April 2025. A total of newly diagnosed diabetes mellitus patients within 6 months of diagnosis was taken, presenting either on outpatient basis or admitted under Department of Medicine or Endocrinology were used using convenience sampling, and all patients underwent detailed clinical evaluation, lab investigations and echocardiography, and in collaboration with the Department of Cardiology, and sample size was calculated as 113. Later data was analyzed, and Mann-Whitney and chi-square tests were used to assess the correlation. And coming to inclusion criteria, patients of age between 35 to 60 years were taken, and patients diagnosed with diabetes within 6 months of detection and with informed consent for the labs and echocardiographic evaluation. And as per ADA guidelines, FBS more than 126 milligram per deciliter, and postprandial post 2 hours glucose more than 200 mg per deciliter, and HbA1c more than 6.5 and RBS more than 200 with symptoms were taken as inclusion criteria for diabetes. And exclusion criteria, all other diseases such as hypertension, ischemic heart disease, heart failure, cardiomyopathies, atrial fibrillation, and CKDs, COPDs, thyroid dysfunction, severe anemia and hemoglobinopathies, and malignancy on treatment, and pregnant women were excluded, as all these diseases might have diastolic and ventricular involvement in any other way. So after that, the results were analyzed. Coming to the demographical and anthropometric data, most participants were aged between 41 to 50 years, and followed by 47.8% were 41 to 50, and followed by 51 to 60 were 35.4% of population, least was 35 to 40, and more proportion of males compared to females noted, and most participants were overweight, followed by normal BMI, and obesity class 1 was 16.8 and underweight was 1.8, median BMI was 26.8, and median waist and hip circumference were 90 and 100 centimeters respectively. Coming to laboratory data, median total cholesterol triglycerides HDL were 195, 156, and HDL was 38, LDL of 120, and TC by HDL ratio was 5.4. Median HbA1c was 7.8 among all population, indicating a poor glycemic control, and diastolic dysfunction was present among 38 participants out of 113, and 75 were completely normal, and ejection fraction was 66%, and mild LVH was also seen in 13% of the population, 13 participants, and 11.5% of the population. So population was divided into two groups based on HbA1c less than 8.1 and more than 8.1. There was no statistical differences found in age or sex. Group 1 had more obese and overweight, and group 2 had normal or low BMI. Group 1 had significantly higher BMI, 27.4 compared to 25.1 in group 2, that is more than 8.1. And waist circumference and waist to hip ratio was significantly higher in group 1 compared to group 2, and FBS, PPBS and RBS were higher in group 2, that is in the more than 8.1 HbA1c population. However, there were no statistically significant differences noted in lipid parameters, that is total cholesterol, triglycerides and LDL, HDL. So this was analyzed, like the population was divided into normal and abnormal. Abnormal was with the patients with diastolic dysfunction. In this, the median age for patients with diastolic dysfunction is 52, a slight higher age compared to the normal group, which is 47, and waist and hip circumferences were significantly lower in the abnormal group than in the normal group. Waist to hip ratio was also lower in the abnormal group. So HbA1c and RBS were also significantly higher in the abnormal diastolic dysfunction population, that is 9.1 HbA1c in the abnormal group versus 7.4 in the normal group. This suggests a strong association between poor glycemic control and diastolic dysfunction. Other variables such as total cholesterol, triglycerides, LDL and HDL were not statistically significant in between these two groups. So diastolic dysfunction had worsened glycemic control. After performing a logistic regression, HbA1c, a marker of glycemic control, which showed a statistically significant association in the unadjusted analysis, became non-significant in the adjusted model. And age emerged as a significant predictor of diastolic dysfunction in both unadjusted and adjusted logistic regression models. Discussion prevalence of 33.6% of asymptomatic diabetes patients noted, and glycemic control significantly higher HbA1c and RBS noted with LVDD, and HbA1c stratification, LVDD was more prevalent in patients with more than 8.1, and age association had median age of 52 versus 47, and the highest prevalence was in the 51 to 60 age group. So the age increases, the prevalence of diastolic dysfunction increases. Anthropometry, waist circumference, hip circumference and WH are significantly lower in the LVDD group. So interpretation, the inverse association may reflect sarcopenic obesity, altered body composition and non-obese diabetic phenotypes. No significant association of lipid parameters noted among the diastolic dysfunction. And conclusion, in this study, 33.6% of asymptomatic newly diagnosed diabetes had diastolic dysfunction, indicating an early cardiac involvement, and age and poor glycemic control associated with LVDD, and dyslipidemia showed no significant correlation. These findings highlight the need for early cardiac screening and optimal glycemic management in diabetes to prevent diabetic cardiomyopathy, and screening in elderly population with poor diabetic glycemic control is indicated.
Thank you. What is the paradox in your study and how will you explain that?
So in my study, paradox is the diastolic dysfunction had the lean BMI is lower on the diastolic dysfunction groups. That may be due to the poor glycemic control, which causes weight loss per se, like due to the diabetes control itself, or the older population usually has lean body mass, sarcopenia. So that is the reason which can be explained in this study. So like as per
probably nuanced diabetes, and you are included only nuanced diabetes.
Only nuanced diabetes.
So that is the likely explanation. Yes. That will explain the paradox. And did you adjust for female sex and obesity BMI for regression analysis in the differentiation?
Female age was not
because diastolic dysfunction commonly
age and the other parameters were taken. Gender, females and males was not.
BMI was not adjusted.
BMI was adjusted, sir.
Okay.
What is your criteria for diastolic dysfunction? What echocardiographic criteria did you choose?
Parameters, sir, we have taken E/A ratio across the mitral valve, and also LAVA, left atrial volume index, that is more than 34, and also E/E septal velocity. And these three, like usually E/A more than 1 we have taken as 1, and there is a reversal, and as per the criteria of ESC guidelines, we have taken that considerations, and we have taken that grade 1, grade 2 also. Like we have graded. So but everyone was grade 1.
Yeah, all the patients that in this group were asymptomatic, or
so everyone was asymptomatic without any symptoms of cardiac failure or any other signs of cardiac failure. So completely asymptomatic patients just who came for screening, or patients who came for like any surgical opinion or anything. Those patients who were incidentally detected were also taken.
And anything else that like NT-proBNP or cardiac troponins?
NT-proBNP was not done.
You are not done it. And what is the relevance of this information for general.
Yes, usually patients who are newly detected with a poor glycemic control, if HbA1c is more than 8.1, or elderly population, that is if it is more than 50, or in this 50 to 60 I had like age as a significant factor for diastolic dysfunction. So these populations can be screened with echo and should be strictly controlled with diabetic management, so that they might not go into overt heart failures.
So is there any strong clinical trials to suggest the information you last told, where intensive glycemic control will result in reduced heart failure outcomes or LVH regression? Any scientific information to support that as of now?
No, as of, I know that
Okay.
everyone was normotensive. That was the exclusion criteria. So
how do you explain that lower waist circumference and situation for the patients with
LVDD with lower waist
circumference compared to the
in the diastolic dysfunction.
yes, in the diastolic.
So one is like the age and the poor glycemic control can muscle mass, and that thing was one of my explanations. Yeah, that was the only paradox which I got in my study. Like the BMI and everything was low in the poor glycemic control. So one thing was the uncontrolled diabetes, and the age itself was a factor, because more age group was higher age group was found in the diastolic group. So maybe sarcopenia or